go ahead and get started. For those of you who don't know me, I'm Danielle Tholey. I'm one of the fourth-year transplant fellows, and I'm going to be talking about vascular issues in liver disease today. So I wanted to start out with a brief case presentation. So this is a 50-year-old male with a past medical history of hep C cirrhosis. He has a MELD score of 25. His liver disease has been complicated by ascites, SBP, and a history of small, non-bleeding varices. He also has a history of CKD stage 3, and basically presents to the emergency department with abdominal pain. So he's a child B cirrhotic. He's not yet been worked up for transplant, as he's never seen a hepatologist before in the past. His other past medical history is significant for a provoked DVT after a surgery he had many years ago. He finished a course of warfarin for that. And he does remember saying that his INR was quite labile, is what his PCP told him. It's a very educated patient. And then his vital signs were all stable. On physical exam, he had significant jaundice, ascites, and mild tenderness to palpation. So pertinent labs are below. He had borderline thrombocytopenia, T-bili of 3, creatinine is 2, which is at his baseline. AST and ALT were elevated in the 300 to 400 range, and mild alk phos elevation to 200. So the ED obtained some imaging with an ultrasound, which showed an opacified portal vein, no mention of any cavernoma. They were limited with further imaging because of his kidney function, but luckily he had a recent ultrasound which showed no evidence of clot. As a result, he's diagnosed with an acute portal vein thrombus. And then the emergency department calls you at 4:59 and they ask you, what should we do next? So these are some of the different considerations in thinking about what choice of anticoagulation you would use in this patient. So he has renal dysfunction, prior history of labile INR on warfarin in the past, child's B cirrhotic, and then we don't really know anything about this patient. This is the first time we've ever seen him, so unclear what his transplant status would be at this point because we're just meeting him. And I'll come back to these points as we go through the talk. So key questions. So I broke up my talk into several different mini topics, and I'll go through each of these individually, although the area that I wanted to focus most on is direct-acting oral anticoagulants, or DOACs, as I'm going to call them for the rest of the talk. And the reason for this is I think the use of DOACs in patients with cirrhosis is not always as clear to us. And I really wanted to delve into what is the literature behind them and what's the safety and efficacy of using these agents in patients with cirrhosis. Other things I'm going to talk about are what are the treatment options available, how effective is our standard of care treatment so we can have an adequate comparison for the role of direct-acting oral anticoagulants in cirrhosis. Is there a role of prophylaxis of PVT? And does anticoagulation offer any additional benefits beyond just reducing clot burden? Okay, so a couple words about epidemiology. So portal vein thrombus is very rare in patients with compensated cirrhosis, but as patients develop decompensated liver disease, this increases to about 8 to 25%. Patients on the transplant list have an incidence of PVT of about 7%, and this incidence has been increasing over time. So why do we care about this topic, and what's the big deal with portal vein thrombus? I think the reason we really care is that there have been many studies showing that outcomes are poor in patients who have a portal vein thrombus. There's a higher risk of waitlist drop-off, reduced post-transplant survival, and an increased risk of uncontrollable variceal bleeding, secondary to increased portal hypertension. So this is a study here that looked at post-transplant mortality in a sample of 250 waitlisted patients. And then looking at the number, they basically compared patients who had no portal vein thrombus or partial portal vein thrombus to those who had complete thrombus. And not surprisingly, patients who had a complete thrombus had much worse post-transplant survival at about 50% as opposed to 83% survival in those who had no or partial thrombus. So I think no talk on portal vein thrombus would be complete without a picture of the coagulation cascade. Still gives me some nightmares from residency. And looking at this diagram here, I think this is something we all know, that the INR and PT, PTT are not reflective of the underlying state of how coagulated or anticoagulated a patient is. But sometimes it's good to remind our colleagues in other fields of this. As we know, factors 2, 7, 9, and 10 are all decreased. However, factor 8 is much elevated, which is a very strong procoagulant factor in the liver. And then other naturally anticoagulating factors are often decreased, like protein C and S. So our patients often have more of a auto-regulated state than we often imagine, and sometimes are even more on the hypercoagulable side. So this is some of the studies that just briefly talk about this. There's a very large study done by Northrup's group looking at incidence of PVT and DVT in patients who were hospitalized and found that the rates were actually equal between cirrhotics and non-cirrhotics. There's also a very large cohort study that came out of Denmark looking at 100,000 patients, again, with DVT, and found that the risk of DVT was actually higher, about 1.5 to 2-fold in those with cirrhosis, implying that they're probably more balanced or at least balanced anticoagulation status versus potentially even hypercoagulable. So what are the treatment options in patients with thrombotic disease and cirrhosis? This is more review. As we know, Lovenox and warfarin are the agents that we've been using forever. The pros to using these agents is there's tons of literature supporting them. They're reversible, well studied, although they definitely have a lot of downsides. The INR is affected. There's a lot of liability with using this, which can predispose to more bleeding, and it's hard to know when the patient is really therapeutic because many of our patients already have a high INR. That's where I think the direct-acting oral anticoagulants come in. They have a lot of benefits. The INR is not affected. They become therapeutic pretty much immediately with use. There's less monitoring that's needed. However, on the flip side, certainly there's limited data, and there's no reversal agent for a lot of these different medications.
Sarah, where would aspirin fit in?
So
I see it's not on the list.
Yeah, so we don't typically use aspirin for portal vein thrombus because it's more of an antiplatelet agent, as you know, so I think it's just not as strong enough of a anticoagulation in this setting.
What about prophylactically?
Prophylactic. So I think prophylaxis of portal vein thrombus is actually interesting. I'm going to talk about that at the end of the talk. That's actually a really great question. But I'll come back to that. So this here is just, again, the same slide showing some of the evidence. And as you can see, there are a much greater number of studies looking at data for warfarin and Lovenox, where it's very limited in looking at direct-acting oral anticoagulants, given how new these agents are. So number one, just a couple words on how effective and safe is our standard of care treatment. Although we've been using these agents for a long time, there still are not a lot of large, well-designed studies. Many of the studies that exist have a lot of variation in their design, forcing us to rely on small retrospective studies and meta-analysis. So this here is a recent meta-analysis from 2017, looking at about 200 different patients. And as we know, obviously Lovenox was superior to control in terms of causing recanalization, although it's not that high of a rate. It's about 57, which is what we've seen in 57% rate of complete recanalization, which is what we've seen in prior studies. This is just that we have a comparison for DOAC use. Probably more interesting is what's the safety of these agents that we can compare for later. And they also looked at rates of overall bleeding as well as variceal bleeding in the study. And in looking at overall bleeding, there was really no increase in patients who were on anticoagulation as compared to patients who weren't. And the rate that they found was about 11% risk of bleeding, so not insignificant. They also looked at rates of variceal bleeding with 4 different studies of about 150 patients, and actually noted, interestingly, that bleeding rates were lower in patients who are on anticoagulation at about 2% compared to about 12% in controls. This is likely because of the immediate reduction in portal hypertension and probably less risk of variceal bleeding for patients who had acute thrombus. So what exactly is the role of direct-acting oral anticoagulants in patients with cirrhosis? As we talked about before, there's many potential advantages, although there's not a lot of great data. So we basically need more data, but I'll go over what we have. So looking at the bleeding risk, this again is just to give us a framework. So first looking at, because studies of DOAC use in patients with cirrhosis are limited and small numbers, I wanted to first look at what's the data in just patients without cirrhosis, so we have a baseline risk. So this is one of the larger studies that's well known, looking at about 25,000 patients, putting together 5 different randomized control trials. They had half of patients on Lovenox, half of patients on DOACs. And what they found is that over all patients in the DOAC group had lower rates of major bleeding and fatal bleeding compared to those who were on Lovenox. Rates of fatal events from clotting or stroke was equal between groups, so there was no difference in efficacy. And overall, the composite fatality rate from either bleeding or clotting-related events like stroke or progression of clot favored those who were on the DOAC. So now this is all of the studies I could find looking at DOAC use in patients with cirrhosis. So obviously it's not a very impressive slide, and that's because there aren't really a lot of studies thus far. These are small retrospective studies, but in the data that we have, VK is pictured in blue, on the graph here, and DOAC use is pictured in the pink or red bar, and there was no significance in overall rates of bleeding between DOAC use and Lovenox use in this group of patients. And some may even say that there was a trend towards lower rates in the DOAC group. So I'll go over these studies individually. The study that was done by Hum is a retrospective cohort of pretty sick patients. They were all Child's B cirrhotics. They looked at 45 different patients comparing DOACs to traditional anticoagulation and followed them up for a long time, so 3 years in total. As we mentioned previously, there was no difference in the overall rate of bleeding between those on traditional oral anticoagulants and DOACs, but the rate of major bleeding was found to be significantly lower in those who were on a DOAC. The authors also were able to tease out the different events that were occurring in the groups, and they found that there was a much, although not significant, a very strong trend towards lower rates of intracranial hemorrhage in those who were on a DOAC compared to those who were not. And I think that's an important point because obviously coming back from something like an intracranial bleed is not something that we can do versus GI bleeding. While we don't want that to happen in our patients either, that's something we're more comfortable dealing with, and we sometimes have measures to reverse that.
And just going back really quickly to the study you showed about variceal hemorrhage risk, those were all in patients who have not had prior variceal hemorrhage, is that correct?
Sorry, which slide? In the slide here?
Yeah.
Yes.
Patients when had prior variceal bleeding.
That's a great question. I don't know the answer to that, but I can find out for you. And then in terms of efficacy, there was really no difference in efficacy for clotting events in those who were on a DOAC or on traditional anticoagulation. This is the other main study that was done, looking at patients comparing the two rates of bleeding. They looked at 39 patients, again, on DOACs versus traditional anticoagulation, and their major outcomes were type of bleeding, so major, moderate, or minor bleeding. They defined major bleeding in the study as fatal bleeding, drop in hemoglobin of greater than 2 grams, or requiring more than 2 units of transfusion. Minor bleeding was pretty much clinically insignificant, not requiring any intervention, and moderate bleeding was in the middle. And the results of this are pretty much the same as the prior study. No difference in overall rates of bleeding. Again, there was a trend towards less major bleeding in the DOAC group, although not actually statistically significant in the study, with the caution being that all of these studies are small. Again, they looked at the different breakdown of the rates in these groups, and there was no real difference between rates of intracranial hemorrhage or GI bleed or type of bleeding event between the two different oral anticoagulant agents. In terms of causes of discontinuation, it's hard to really interpret a lot about this because, again, the numbers are small. Although one of the things that seems positive about the DOAC group is more patients were taken off therapy because they actually had resolution of their clot as compared to the traditional anticoagulation group. I'm going to come back to DILI a little bit later in the presentation, but that's one of the concerns that's been raised with some of these novel oral anticoagulants. And in this particular study, they did not appreciate any DILI in these patients. All their LFTs were very stable. And type of anticoagulation was not a significant predictor of bleeding. Finally, this is the last study I was able to come across that basically looks at DOAC use in cirrhotics compared to patients who do not have cirrhosis, trying to define is what we're doing in patients who have cirrhosis an acceptable risk, or is the risk much higher than what we would expect in a non-cirrhotic patient. So this was a multi-center study looking at a total of 94 patients, 36 cirrhotics, and 58 patients without cirrhosis. The rates of the different anticoagulants are pictured here on the left-hand side, and the patients were on roughly the same proportion of novel agents between the two different study groups. Of note, patients in the non-cirrhotic group were followed for a much longer time period, about 10 months more than patients who were in the cirrhotic group. And again, in looking at the cirrhotic group, patients were Child's A, MELD score of 10, so relatively a healthy population compared to what we typically see. There are also some significant differences in groups, unfortunately. More variceal bleeds in the non-cirrhotic group versus patients in the cirrhotic group were older, had more ascites, more SVP, and more varices. And what the authors found at the end of the day was that there was essentially a lower rate, if you can really call it that, with such small numbers of GI bleeding with the cirrhotic group as compared to the non-cirrhotic group. But it's maybe encouraging that it's not higher than in the traditional group. Additionally, they looked at overall adverse events rates, which were similar between the two groups, and also at efficacy, and there was no difference in the efficacy of agents between the two groups. and no change in child's Pew or MELD score, signifying that patients are not developing decompensated liver disease with the use of these novel agents.
So what were they using them in non-cirrhotics for?
So there are patients who are getting it for either portal vein thrombosis related to like NRH or like splenic vein thrombosis. So it's like some other thrombosis, like either splenic or portal, but not in the presence of cirrhosis. So, yeah, it's a little bit different.
And they're still having variceal bleeds in non-cirrhotics.
And they're still having more variceal bleeds, yeah, which is, so they must be having a lot of portal hypertension, which I definitely think could be one of the critiques of this study is their patient population sicker than maybe the other patient population, given the fact that they're having more variceal bleeds and stuff, certainly. And in terms of overall mortality, patients in the cirrhotic group only had a bleeding rate of about 2.5% over the course of the study, and there was no mortality in either group with the use of these agents. That's a good question. I don't know why the follow-up time was so different. It was a retrospective study, so I don't know if they were just lost to follow-up. Although in looking, I don't know. So I think we already discussed a lot of this. Certainly the study has to be interpreted with care because there's a lot of potential critiques to it. You know, was the one group sicker than the other? It's not randomized. The patient groups may not have been matched well. Certainly generalizability is a question given this is a much healthier patient population than what we typically see. And there's a big difference between the follow-up in the two groups, which could give the non-cirrhotic patient a lot more chance to have negative events occur. This here is just a summary of all of the studies we've already talked about. Again, in summary, major bleeding rates in the DOAC group are lower or at least not higher than patients who are on traditional anticoagulation. And although numbers are small, all of these studies had actually pretty extensive follow-up time that you would expect to see some sort of bleeding within this follow-up. So in addressing the risk of DILI, because this has been one of the concerns that's been put forth with these novel agents, the risk of DILI has been projected to be about 0.1 to 1%. You do have to think about altered metabolism as patients' liver disease progresses. What will it do to the use of these agents? And this table shows the results of several, unfortunately, again, small pharmacokinetic studies that look at changes in the potency of the drug over varying child Pew score stages. And far and away, what they found is that patients in the Xarelto group had the greatest change in potency as their liver disease progressed. So as they went from child A to child B, they had a relatively 2.5-fold increase in the potency of the drug. There was no evidence of any bleeding episodes in those patients, but because of this increase in potency, it's only really recommended for child A cirrhosis. Apixaban, on the other hand, was very neutral. There was really no change in potency levels as patients went from child A to child B. They even looked at it in patients with renal dysfunction and increased by like 0.3%, so still pretty stable. Although I don't think it was looked at in like end-stage renal. And then it's really recommended for child A and B. It's not recommended in C, but that's more because there's been any negative events that have been recorded in patients with child C cirrhosis. So we just don't have enough information. And then Pradaxa, interestingly, had a decreased potency as patients progressed from child A to child B. So there's been no formal restriction put forward. In looking at a large study of different cases of DILI with direct-acting oral anticoagulants, Xarelto was recorded as the one that had the most number of cases, although it was very close to Pradaxa. And apixaban was extremely rare. Only one case had been recorded in that particular series. There were rare cases of serious drug injury in a study of 700 cases. 24 had acute hepatitis, and 4 patients did develop acute liver failure with Xarelto. This here is another large meta-analysis looking at the risk of DILI in patients who are on DOACs. They use as their primary outcome Hy's law, or LFTs greater than 3 times the upper limit of normal, and T-BILI greater than 2 times the upper limit of normal. And what they found at the end of the day was that there was really no increased risk of DILI using this criteria in looking at all the DOACs together and then looking at all the different drugs individually. Apixaban, Pradaxa, and Xarelto, none of them had an increased risk individually. So this is the question that you asked about earlier. Does anticoagulation have any additional benefit, and is there a role for prophylaxing against portal vein thrombus? And this is an interesting study that I came across. There wasn't a lot in the literature about this point, but they basically did a randomized control study looking at efficacy of Lovenox in preventing TVT, and they used a sick patient population, child B and child C cirrhotics. They excluded patients who had had a decompensation in the prior 3 months, but that doesn't mean that they had to not have decompensated liver disease at all. They could have prior decompensations, just not one within the preceding 3 months. They excluded patients who were over 75 and those who had any sort of predisposition to clotting, so HCC or hereditary clotting disorders. They were able to be included if they had varices, so long as they had been banded. They essentially looked at 34 patients in the enoxaparin arm and 36 patients in the control arm. The primary endpoint was 2-year prevention of portal vein thrombus or mesenteric thrombus. Secondary endpoints that they looked at were decompensation, overall survival, and reduction in markers of bacterial translocation. And I think what they were trying to get at here is, can you actually decrease the risk of infection as well? All these patients were put on Lovenox for a total of 48 weeks, and then they had CT scans every 6 months, up to about 120 weeks total, looking for clot progression. So the graph here shows, not surprisingly, that patients in the Lovenox group had a much lower probability of progression to portal vein thrombosis compared to the group of patients who were not on anticoagulation. What's maybe a little bit more interesting is that despite being stopped on having their anticoagulation stopped at 1 year, they seemed to gain a protective effect for an extra year, as none of those patients still had developed clot at 2 years despite being off anticoagulation. Those patients eventually did develop clots, although it was very late, at around 105 to 121 weeks. And overall, the rate of the patients who had received any Lovenox was still much lower than those who had not received any sort of anticoagulation therapy. So then the authors also looked at whether or not Lovenox could help reduce the rates of decompensation. And they looked at this in child's Pew score. And this graph here shows change in child's Pew score by 2 to 3 points over time. And again, patients in the Lovenox group seem to have less decompensation over time than patients who were in the control group. They also noted that these patients on anticoagulation had lower length of stay and less admissions. And then importantly, something that concerns all of us, there was not a higher risk of bleeding in either of the groups over time, despite being on this prolonged course of anticoagulation. So this I included just because I thought it was kind of personally interesting, and there's not a lot of data for this, but whether or not infection risk can be decreased by the presence of using, anticoagulation for preventing clot. And what they found in their study is that there was a significantly lower rate of infection, in about 8% in the Lovenox group as compared to about 33% in the control group. And the way that they did this is obviously looked at overall rates of infection, but they also looked at molecular markers. So they looked at IFABP, which is a marker of enterocyte death, with the thinking that the more enterocytes that are dying, there could be more intestinal permeability and then a higher risk of translocation. They looked at IL-6 as a marker of inflammation, and then levels of bacterial DNA. And what they found is that in the group of patients who were in Lovenox, during the active phase of treatment, all of these markers of infection decreased. So decreased enterocyte death, decreased inflammation, and decreased bacterial DNA levels. In patients who were in the control group, they had progressive rises in enterocyte death markers, inflammation, and bacterial DNA remained static. Not surprisingly, once you removed these patients from having the benefits of Lovenox, their rates started to climb again over time. And then the theory for why Lovenox may help to prevent the risk of infection is basically tied to portal hypertension maybe predisposing to these microthrombi, and that being a setup for more enterocyte death and then translocation over time. So the thinking is that maybe by putting them on some sort of anticoagulation, you can prevent these microthrombi from developing. And then finally, and most importantly, they looked at whether there was a survival benefit. And in this particular study, they actually did find a survival benefit in patients who had Lovenox as compared to control, and that Lovenox was an independent predictor of survival. There also seemed to be less cases of liver-related death in the, more cases of liver-related death in the control group as compared to the Lovenox group.
You can have a platelet cutoff beyond which which they want their patients to be, or there was no consideration for what the platelet count?
What the platelet count was? Yeah, they did. I think it was like 40,000 is what they recommended in their study. I don't know how exactly they came up with that number. It seemed a little bit like, usually we go with like 20 or 50, that 40 seemed kind of random to me, but they didn't really explain why they chose 40,000. I don't know.
That's the battle we face. I mean, a lot of patients with platelets of 30,000 and 20,000.
Totally.
So, and at least as we send them to hematology, they won't put them on a blood thinner.
Yeah, for sure.
So intuitively, it should have. Ease up on hypertension.
Right, you may have less decompensation in all of these portal hypertensive sequelae.
So 40,000 is enough.
So 40,000 is what they recommended. Yeah. So in conclusion, portal vein carries significant rates of morbidity and mortality. The data is limited in the existing small studies that we have. Direct-acting oral anticoagulants appear to be safe and just as safe as traditional oral anticoagulants. And then finally, anticoagulation may have benefits beyond clot reduction in terms of reducing decompensating events. So in going back to our case, some things to consider, given the patient's renal insufficiency, Lovenox is out for him because his GFR cutoff is too low. Not that you'd want somebody, ideally on this for a long term anyway. He's Child's B cirrhosis, so as we discussed, can't use Xarelto in him because the potency is going to be too elevated. So that leaves you with the options really of warfarin or apixaban in this patient. He has a high INR already, history of labile INR in the past, so maybe you'd think about apixaban versus warfarin, but certainly would not be wrong to continue warfarin use in this patient. And I think the last kind of interesting piece, which I didn't talk about, is if he had been on the transplant list, what would be your option then? I think most of us would probably feel most comfortable with warfarin, given it's reversible, it's sort of tried and true. Although there are some, it's only case study based, but some case studies looking at patients on Pradaxa who are on the transplant list because it does have now a reversal agent, and they look at how the patients did after transplant and actually did fine, no increase in the bleeding risk, and all of the patients left with a pretty uneventful stay. So maybe in the future, but I don't know that I feel comfortable doing that right now. They all did. They got the Ida-Ruzumab, I can't pronounce it, but yeah, whatever the antibody is that reverses it. And what they did on a lot of them is they actually had them on apixaban, and then once their MELD score started to get high enough where they might start getting offers, they switched them over to Pradaxa, and they used a reversal agent before the surgery. Yeah. And that's it.